Okay, we're up to a nice group of people on the phone, and I want to be respectful of everyone's time. Um, we make sure that these webinars are exactly 1 hour long, and so I don't want to get started too late. I want to give Dr. Fisher time to go through his slides and to talk a little bit about this incredible program that he has that's being shared in many countries around the world. For many of you, this is your first interaction with the United Patients Online Academy. I wanted to take a minute to discuss what the United Patients Online Academy is and what our dynamic is and what we hope to achieve as time has gone on. United Patients Online Academy is a digital platform for training advocates and health NGOs to help NGOs and advocates run their institutions in a more efficient way. We have an online training program which is run by experts where we have 5 modules, one on strategic planning, one on volunteer management, one on fundraising, one on media and communications, and finally on advocacy. So please log on to unitedpatientsacademy.org to see what sort of courses we have. We also have toolkits and resource libraries that help NGOs and advocates see what's happening around the world and get some of the best training available to help them run a more efficient organization. We call it the MBA for NGOs. And so it was started a few years ago. We have over 1,000 NGOs in the world signed up, and we are available in English, Spanish, and Portuguese. And soon we are going to be expanding into a few more languages, which means that there's going to be resources in regions of the world that otherwise have not been available, specifically on how to run an NGO focusing on patient rights, public health, and improving health outcomes and patient treatment and care around the world. And so part of what we do is we try to have experts come on and speak about some of the best practices that are available in patient care or in advocacy or in institutional management. And so the idea is that we try to highlight case studies from other NGOs. We believe that the best way to highlight successes within our community is to have our community speak to our community, and so that's why it's wonderful to be able to highlight some of the case studies that we have. And this is part of the United Patients Online Academy Ask the Expert webinar series. Now that you've registered, you will be also receiving invitations to additional webinar series. We do these every month or every other month, and so some months might be interesting to you, some months might not be interesting to you, but since it's a free webinar and available for your participation, we leave it to you to participate or not participate depending on your timing or your interest. If it is a webinar that you are interested in and you were not able to attend, we record all of these webinars, and then we make them accessible on unitedpatientsacademy.org in the resources section. So if you were not able to attend a webinar because of some of the timing issues, please feel free to go on to unitedpatientsacademy.org into our resources section and attend the webinar at your convenience. Everything that is available on unitedpatientsacademy.org is at your convenience and tailored to you and your needs. So we hope you take advantage of that. The way that the webinars generally work is we have a short presentation, generally 25 to 30 minutes, by our expert. And today we have Dr. Edwin Fisher. And and then as time goes on, if you're listening to this presentation and you have some specific questions, please see that on the right-hand side there is a section that says questions. Type in your question, and at the end of the webinar, we have plenty of time for questions to be answered, and what will happen is I will read the questions that have been typed in, and Dr. Fisher will answer them to the best of his ability, and he has much ability. So, and then if there's anything that comes up after the fact, or if there are any questions that we were not able to ask Dr. Fisher in the amount of time that we have, we share those questions with Dr. Fisher. You can email us on unitedpatientsacademy.org, or any questions we didn't reach, we share with Dr. Fisher, and we'll email the response to you. So that is how United Patients Online Academy works. This is one of our Ask the Experts webinar series, and now I'd like to talk a little bit about what we're going to be speaking about today. Today we're going to be speaking about a global program called Peers for Progress. And I think this is a very important case study for many of us because it shows the importance of the work that we as the patient support community can have on patients in terms of adherence and also in terms of better health outcomes. I think many times when we are doing our work is very important for our patients, and we know that psychologically our support to them is very important, but sometimes we actually do not see or do not measure or are unaware of the actual clinical outcomes we can see from the types of programs we have. So Peers for Progress is a unique program because essentially what it takes is it creates a structure around the patient support programs that we probably already are doing, and it has evaluation tools so that we can actually communicate and understand the impact we're having. Being able to understand the impact we have on the people that we serve is so important for many reasons. It can be important so that we can make sure that we are doing our programs effectively, so we can identify barriers and identify areas of weakness. It also can be important when we're speaking to donors or policymakers or the media. Being able to really measure and communicate our impact is a very important skill and something that Peers for Progress is focused a lot on. And what I also think is interesting about Peers for Progress is that it's a joint program. It works very closely with the clinical community, with doctors and nurses, so that the clinical community as well understands the importance of peer support, patient support, and the ongoing role of connecting patients with patients, so that once the patient leaves the doctor's office, that they are not abandoned and that they enter into a network that can be supportive of them and can be helpful to them as they recuperate from a surgery or they deal with an ongoing chronic illness such as diabetes or heart disease. And so I think that being able to involve clinicians on this clinically proven program is very important, and I hope you agree. I'd like to introduce a great colleague and friend, Edwin Fisher, who is a public health official and also a researcher. He received his degree from Stony Brook University in clinical psychology, and he's the former chair of the Department of Health Behavior at the University of North Carolina, Gillian School of Public Health. He has a wide range of research interests, and he serves, as I mentioned, as a global director for Peers for Progress. And this program documents the benefits of peer support, of diabetes management and other chronic diseases, and conducts diverse activities to promote peer support around the world. And I think that around the world element is going to be very interesting for us because there's a lot of different examples from a lot of low resource settings that, that show that this kind of program can be beneficial. Since he's a researcher, he has also created a wonderful evaluation structure around the work that he does. And I know from having worked many years with small groups and NGOs, sometimes evaluation is the thing that comes last, we do last, and sometimes we don't do it all. So I want to encourage that we take a look at Peers for Progress and we listen to what Dr. Fisher has to share with us. And we think a little bit about the work that we do, the clinical impact we can have, and how to measure it and communicate it effectively. So, Dr. Fisher, please take the reins and share your experiences and your knowledge with us.
Thank you so much, Alessandra, and it's really a pleasure to be part of United Patients Online Academy webinar, to work with Alessandra and her colleagues, and to have the opportunity to talk with all of you about what I believe in and what I love. Let me just mention two things. One is, at the end, we're going to talk a little bit about the possibility of networking around peer support. So this presentation is really an introduction, and if you're interested in pursuing some of the possibilities we outline, we would really look forward to having contact and interaction with you afterwards. Also, I'm going to try to speak quickly and get through my slides quickly, but I also want to be clear. If you're having trouble understanding me or need me to slow down, just type a little note to Alessandra, and Alessandra will break in and tell me to slow down or speak up or be more clear or whatever. So with that, I want to start talking about peer support, and I want to start with an example. This is a project that was done in Anhui province in China, led by a good friend and colleague, Dr. Zhifang Zhang, in the Centers for Disease Control in Anhui province. Through community health centers, she recruited older adults, and they were trained to be peer leaders for other people with diabetes. The man on the right in the picture is a farmer who moved after retiring to the city, and he now leads a walking group every morning. The man in the middle in the picture is a retired school teacher, and he leads a Tai Chi group every day or a couple of times a week. So the peer supporters laid group meetings monthly with health center staff, where people with diabetes can have their questions answered, talk about how they're doing. And then they also have informal group meetings led just by the peer supporters that address self-management and support issues. In addition to the group meetings, there's informal support through shared activities in neighborhoods, people shopping together, exercising together, even fishing together. And over the course of a year or so, this project showed significant differences from controls on fasting glucose, 2-hour postprandial glucose, and reported complications. And the Centers for Disease Control in Anhui have extended it to cardiovascular prevention and management. So this has been a successful program, but you can see it's really a very simple program. It's probably something that you can see how you might be able to do something similar in your setting. I want to emphasize the breadth of peer support. It includes informal support from family, friends, neighbors. It includes volunteers to provide specific support. For example, perhaps volunteers working a few hours a week with new mothers. In Thailand, there are thousands of village health volunteers who have been part of the health system since about 1968. In Pakistan, there are thousands of lady health workers who work through primary care and serve about 80% of the rural population of Pakistan. It includes mutual support groups. In the United States, for example, we have a number of support groups for women with breast cancer where they help each other deal with the stressors that disease brings to them. And it also includes increasingly online or text support. The web, digital health are becoming important avenues for peer support. Across all of these, Peers for Progress has emphasized what we call 4 key functions of support, and they're really pretty simple. Assistance in daily management. As one patient put it, the doctor and nurse help me figure out what I need to do, but the peer supporter helps me figure out how to do it. The doctor may convince me that I need to eat more fruits and vegetables, but the peer supporter helps me work out exactly how I'm going to do that in my daily life. It includes social and emotional support. it's hard to stay motivated. And many of the conditions we deal with include a fair amount of stress, and having somebody to talk about it can be a real help in dealing with that stress. It includes linkage to clinical and community resources. People need to use resources, good clinical care. They need to see the doctor when they need to. Many times people with chronic conditions don't get the clinical care they need. But it also includes helping people find places to exercise, pay places to buy healthy food, etc. And peer support needs to include ongoing support, because the kinds of problems we're dealing with are really usually lifelong. And it's not enough just to give somebody some help for a few weeks. We need to provide ongoing availability of support. We also think of peer support as across the prevention and care continuum, from primary prevention, peer supporters helping people get screened for cancer, helping people get flu shots or TB screening, on out to helping people manage diseases like diabetes or cardiovascular disease, and on out to palliative and end-of-life care for families and people who are coming to the end of life. Now, there are some real strengths of peer supporters that I want to emphasize. One is that peer supporters share the perspectives and experience of those they help. Peer supporters, people dealing with a peer supporter can know that this person can understand what it's like for me. Frequently, if you're a physician and you're dealing with a patient, the patient thinks, well, you're a physician, of course it's easy for you to say that, but it's harder for me to do that. And the peer supporter helps me feel that somebody really understands what it's like for me. Also, people believe them because they are like me. Research on how people change their opinions shows that we look to experts to tell us something is important, but we look to other people like me to make us feel that we can do it. So the doctor may convince me that I need to eat more fruits and vegetables, but talking with somebody who is like me and who has succeeded at that makes me feel that, hey, I can do that. The doctor tells me it's important, but the peer helps me figure out how I can do it and to feel confident that I can. And importantly, peer supporters have time. Across a whole bunch of research, we know that time spent with patients is critical in helping them change their behavior. And the peer supporter is the person who has time to talk with people, can get phone calls, meet people in the community, and really be able to spend time with people. Now, why does peer support matter? There are a couple of reasons. First of all, I'm very fond of this very simple model. If we include leap years, there are 8,766 hours in a year. If a patient spends 6 hours a year in a doctor's office or with some other health professional, that's probably a lot. That's probably more than most people will spend with a doctor or a health professional. That leaves 8,760 hours a year that people are on their own to do all the things listed here. Eat a healthy diet, be physically active, monitor their status if they have diseases like diabetes or heart failure, take medications, manage sick days, make sure the flu doesn't really make their other diseases much worse, manage stress, deal with healthy coping to deal with stress, arrange medical appointments and testing. For many people, it's hard just to keep track of all the times that we need to go to the doctor. And I've added there sleep, because so many of us are realizing how important sleep is. We haven't given it the attention it deserves. So this is just a sample of the many things that people have to do in those 8,760 hours a year. But that's why they need patient education programs. That's why they need community-based programs. And we think that peer support can be really helpful in this. Now, I don't want to spend too much time on this slide, but it's very important. The picture at the left is a study done back in the 1950s by a psychologist, Harry Harlow. And before Harlow did this study, psychologists thought that the reason babies were attached to their mothers was because mothers were the source of milk. And Harlow questioned that, and he decided to develop an arrangement where the little baby monkey had a choice between, excuse me, had a choice between a soft cloth-covered mother on the left or a wire mother on the right that provided milk. And no surprise, what he found was that when they were hungry, the babies went to the milk, but at other times, the babies went to the soft terry cloth mother on the left. And Harlow did this in a whole bunch of other studies. One that I'm fond of, he arranged a room where monkeys could open a window and look into another room and see other monkeys. But to do that, they had to do work in the first room. And he showed that monkeys would perform effortful tasks just to be able to open a window and see into another room with other monkeys. And so from this, Harlow made the inference that being with others like ourselves is really of fundamental value to primates, human beings. And since then, there have been thousands of studies that show that human beings are more effective and happier when they have someone they can talk to about personal matters, who cares about them, and who can help them when they need help. So this is a fundamental, powerful aspect of human behavior. And it's even been shown in epidemiological studies that the risk of death associated with lacking social connection, with social isolation, is greater than the risk associated with cigarette smoking. So when we talk about social support and peer support, we're talking about a fundamental, strong characteristic of human beings, which is really strongly related to health outcomes. So this is an important thing. If we do it well, it can really be helpful. Now, Peers for Progress is the program Alessandra mentioned in introducing me. We've been very fortunate to work around the world with many people. And in 2009, we funded 8 evaluation and 6 demonstration projects in 9 countries on 6 continents. And I want to show you the results of those projects just in summary terms. And we've outlined them here from feasibility through reach and engagement, efficacy and effectiveness, to sustainability and to adoption. And you can see that we were able to show that peer support was successful with regard to each of those. All 14 projects were able to implement their program, and many of them were in under-resourced settings, so that was an important observation. These were all with diabetes. The average baseline hemoglobin A1C was 8.9%, so you can see that people were reaching and engaging patients who really needed help. The programs improved hemoglobin A1C, body mass index, blood pressure, and quality of life, and other measures. In Uganda and South Africa, the programs have been sustained. And in the U.S., WellMed, which is a large medical group, had extended the program to all 23 of its sites based on their experience with it. In the United Kingdom, the National Health Service is extending the program to additional regions from its initial development in Cambridgeshire. So we can see that from feasibility to adoption, peer support programs seem to be successful. And important to many of us, peer support is also cost effective, and there's a citation there for some studies that we've put together showing the cost effectiveness of peer support. I want also to mention some strategic considerations in how peer support works. Around the world, people are concerned about the people who aren't getting included in healthcare. We put on programs, we put on community programs for obesity, or we institute a new policy in our clinics to try to get care to more people who need it. And we frequently have trouble reaching those who we refer to as hardly reached. And we found that peer support is effective in reaching over 85% of hardly reached groups. among low-income immigrant adults with diabetes in Chicago here in the United States, among single unmarried mothers of children hospitalized for asthma in a major city in the United States. In a systematic review we published last year, 94% of peer support programs were successful with hardly reached populations. So reaching those we tend to have trouble reaching is really an important advantage of peer support. We've also shown that peer support reaches populations. In a project in Chicago, 7 compañeros, as they were called, reached 3,787 adults with diabetes and improved their blood sugar. And another major advantage of peer support is that it improves behavioral health. In a project in Hong Kong, about 20% of the patients were scored high on measures of distress at the start of the project. This was a project for diabetes, but about 20% were really experiencing appreciable psychological distress. For those who were randomized to the peer support condition, that 20% showed real improvements in their distress relative to those in the control condition. And then what was really exciting was the likelihood of hospitalization shown here in the graph. The first bar on the left shows that the people who had high distress and were not randomized to peer support, they had about a 50% likelihood of being hospitalized over 600 days. Those with low distress had much lower likelihood of being hospitalized. But at the right, those with high distress but who were randomized to peer support, they also had a low level of hospitalization. So peer support reduced distress among those who were distressed, and it also reduced hospitalizations among that group who otherwise tend to have high rates of hospitalization. Turning to cardiovascular disease, a recent review looked at studies of peer support with a variety of chronic diseases. 10 of them included papers evaluating peer support for cardiovascular disease, and 9 of those 10 showed positive benefits of peer support for cardiovascular disease. Here's an example, a popular project for cardiac rehabilitation. Peer support was provided by former patients who were trained to help others with cardiovascular disease to promote physical activity, and at 12 months the program members who received the peer support had sustained and improved physical activity. So there's good evidence that peer support can work in cardiovascular disease. Another really important area is with emotions, and as I was talking a few minutes ago, behavioral health. This is a wonderful project in Pakistan that was applied peer support to postpartum depression. They worked with lady health workers who were part of the primary care setting in Pakistan. These are women who have completed secondary education and are responsible mostly for maternal and child health issues for about 100 households. They primarily provide general health education and preventive care. They're working on extending it to tuberculosis and HIV detection and control. And about 96,000 lady health workers cover about 80% of the Pakistan rural population. In this study, the lady health workers implemented a manual-based intervention, Thinking Healthy, for women who were depressed in their 3rd trimester, and it promoted changes in thoughts likely to increase depression, practical problem solving, which we'll get back to, and also collaboration with the family. And in the graph, you can see that those who received the intervention had a 50% reduced likelihood of depression over the first 12 months after delivery. So this was a remarkably successful intervention. for women with postpartum depression implemented by peer supporters, lady health workers in Pakistan. This is an example of one of the cases in a paper by Atif Rahman, the leader of this project. And here it says there was a case where poverty and the husband's chronic unemployment were an underlying issue in the mother's depression. The lady health worker used cognitive behavior therapy techniques to motivate her to take a small loan from the government's microcredit scheme. The money was used to purchase a buffalo to sell its milk for profit. The lady health worker had personal experience of such a venture and was able to guide the woman to do this. The woman was able to return the loan, gain tangibly from the intervention, both materially and in self-worth and confidence, and this led to marked improvement in her depressive symptoms. So what this shows is that the very practical problem solving of purchasing a buffalo for a woman who was experiencing economic pressures was effective in helping her become less depressed. This is reflected in a lot of research now in depression, showing that problem solving for people with depression is probably the core ingredient of effective interventions for helping people with depression. And of course, problem solving is what peer supporters can do very well. So this just shows you, gives you an insight into how peer support can really be effective in dealing with problems like postpartum depression. These are two quotations from patients from the project in Anhui province in China that I showed you in the very first slide. When I knew I had diabetes, I felt that my life is meaningless. When I joined the peer support program, I found that many people have the same illness as me, but they lived very well. Some are more than 80 years old. This encouraged me. I also can live long and healthy. And that's from a 61-year-old woman. And then the next says, I feel that the peer group is like my second family. Normally, I did not like to talk about my illness with other people, but in here I can talk about my disease. We also discuss diet, activities, medicine, and blood sugar control. So both of these show in China how emotional support is a really important feature of peer support. And I think that's important for us to understand. It's not just about teaching people how to eat fruits and vegetables. It's giving them an opportunity to talk about their feelings about the health problems that confront them and to gain strength from the peer support. Now I want to close with some slides on how to do it, how to develop a peer support program. First of all, you would need to consider that there are many modes, many approaches to peer support. Peer supporters can be part of a community-based organization, or they can be linked with clinical providers. Individual trained peer supporters offer assistance, coaching, and being there. So individual peer supporters can be the focus. Or the focus can be group classes and support sessions, community classes, prevention, support of ongoing cardiovascular rehabilitation. Group medical visits are another approach to developing peer support. Mutual help groups, we talked about that at the beginning. For instance, groups for mutual support among women with breast cancer, among other groups with a common disease. These may be self-governing and may just benefit from NGOs and healthcare resources by giving some guidance and some consultation. Experienced leaders are important in mutual self-help groups. It's important that people with some understanding and wisdom lead these groups. Peer supporters can be based in and extenders of group programs. Outreach, patient engagement, and self-management education can come from community or clinical organizations. Peer supporters can be part of the service provider team. So the peer supporter can be part of the team that the patient sees when they come for primary care. That's the model with the lady health workers in Pakistan. or peer supporters can work as extenders and under the supervision of social workers or care managers or others who may deal with more complicated cases, people who need more support and education. Now, how do you recruit peer supporters? First of all, you need to consider whom you want to recruit. They need to have time available. They need to be people who enjoy talking with others. Not all of us have that kind of personality, so they need to be people who really enjoy getting involved in other people's lives and talking to them. They need not to see people's problems as simple. There are no easy answers. The person who thinks, oh, you just have to make up your mind to quit smoking and it'll be automatic, will not be a good peer supporter for people who are trying to quit smoking. They need to be able to learn and teach basic disease management or health promotion behaviors. We'll come back to that a little bit. They need to be willing to use backup support from professionals. This is really important, and we'll come back to it. Should they be volunteers or should they be paid staff? That probably depends on the amount and level of specific duties and requirements. If you want them to be available for a number of hours each week at specific times, then you may need to think about making them staff members rather than just volunteers. And they probably need to share key features with those they serve, whether it's specific diseases or life stages, for instance, people who have just experienced widowhood or living in the same neighborhood or sharing same cultural perspectives. And how can you find these people? Well, frequently people recruit them through clinical providers asking clinicians to identify patients who may be doing a good job of managing their diabetes or their heart disease. You can recruit them through community organizations or through other channels. Training peer supporters is a big challenge for many. It's not as complicated as people fear. The goal is to be able to help others implement their peer management plan, their disease management plan. The peer doesn't need to set the plan. That's for the doctor and the nurse. So they don't need the skills of a nurse or a dietitian or a physician or a physical therapist. They need the skill of a smart patient who understands very well how to manage their disease so that they can then share that understanding of how to do it with others. We also need to teach them skills for simple counseling, like active listening or motivational interviewing is very popular in many peer support training programs, and skills for promoting behavior change, such as problem solving. Implementing the program, you need to think through how will the peer supporters be paired with participants. Will the physicians identify people, or will they be people who just come to a community meeting? How will they be identified and paired with peer supporters? How many participants will each peer supporter manage? Well, obviously that depends how much time they have. Full-time people can manage at various levels of intensity of working with people, can manage several hundred. How will peer supporters contact each participant? Face-to-face, phone, through group meetings, text, whatever. How often will peer supporters contact each participant? What is the schedule? What is the plan? How will peer supporters follow a set curriculum, or will the content of the intervention be more flexible? Or maybe a combination of the two, maybe a set curriculum at the outset, and then as people become more familiar with things, a more flexible approach. The management of the peer support program is important. You need a clearly identified manager of the program. There needs to be a backup plan with questions, issues the peer supporter cannot answer, somebody they can turn to get answers to those questions. And their prompt response to individuals' questions is a real advantage of the program that will be highly valued by the people they serve. There needs to be ongoing support for the supporters, such as through a weekly meeting, shared questions to discuss problems, emotional support for difficulties encountered. Being a peer supporter can be emotionally stressful at times. They need others to talk to about the problems that they're dealing with. And monitoring and supervision is important. It's important because of the importance of the work, not because we don't trust people. When something is important, whether it's surgery or flying an airplane, we monitor it, and peer support is important, so we monitor it. And so the tone of monitoring and supervision needs to be improvement, not surveillance. Everybody's concerned about quality control and misinformation. The key to this is that the peer supporter is basically a good person wanting to help people who often face serious obstacles. They will use whatever resources are available to help the people they're working with. So we need to make resources available, 24-hour backup, emphasize promoting good information rather than trying to control or police information. We should be helping peer supporters have good information to give to the people they work with and not worry too much about trying to make sure they never say anything that isn't absolutely correct. We have a president of the United States now who often mentions things that are not correct. So if he can get away with that, maybe a peer supporter can too. That was a joke. Select peer supporters who are willing to be part of a team. It's important that they be a team player, as we say in the United States, not wanting to be a hero. Clarify that their key role is support and assistance, not professional expertise. And the key is back to what we talked about a minute ago, monitoring, backup, and support for the peer supporter, somebody they can turn to when they need help. Finally, I want to talk about program evaluation. It's important that we understand that program evaluation is not scientific research. I try to use a very common sense approach to assessment, asking whether things happened as expected and whether we achieved our objectives, and if not, can we learn some things that will help us do better in the future. It can be quantitative and statistical or just counting and descriptive. It doesn't have to be fancy. And the purpose really is twofold. We want to guide program improvement. We want to learn things so that we can do better. And we also want to be able to document the value of our program so we can convince people to provide support for continuing the program, and also so we can convince others in similar situations that they might do a similar program. I've sketched out here just an example of a very simple program evaluation in terms of each objective and then just assessing what happened. So our first objective was to develop a curriculum for high cardiovascular risk patients and post-myocardial infarction patients with emphasizing healthy lifestyle. And we're going to ask 3 cardiologists and a health educator from a local university to help develop the curriculum. And they did that. So the curriculum was developed the way we intended. We wanted to recruit and train 10 peer supporters. We were able to recruit 12, but only 8 completed the training. So the next time we may want to look again at the training, or maybe we want to recruit more so that we achieve our target for the numbers completing training. We want to identify 50 high-risk or post-myocardial infarction patients. And here's a common experience I've had. Clinicians originally say, oh, we have hundreds of those patients, but when it comes down to it, they're only able to identify 30. So we need to figure out how to identify more of the people that we know are out there, more of the people we're wanting to help. We want to engage 80% of the eligible individuals for at least 3 months. It turns out we were able to engage 90% of the post-myocardial infarction patients, but only 50% of the high-risk individuals. So the next time we're going to think about how we can do a better job of engaging the high-risk individuals, make the program more meaningful to them. We wanted to get 80% sustained smoking cessation in the post-myocardial infarction patients. We got 83% sustained smoking cessation. That's far higher than the rate if we just don't do anything. And so that's a real success of the program. 80% report 150 minutes exercise each week. Turned out only 72% reported that many minutes of exercise, so we want to do something to improve the exercise. And we wanted to get average blood pressure below 130/90 through medication or lifestyle weight loss, and the average blood pressure got down to 128/85 in the high risk, but 128/95 in the post-myocardial infarction group. So we may want to do something a little bit more with the blood pressure in the post-MI patients. So that's just an example of how you can evaluate a program. We have a comprehensive program development guide that's available online at peersforprogress.org. And if you're interested, it provides lots of resources for developing these programs. And I just want to close by talking about collaborative networking. As we mentioned at the outset, we're hoping that out of this, we can develop a network of groups who are interested in peer support, and we can work with them to share resources and to help each other develop programs, publicize programs, share evaluations so we can convince others of the value of these programs, things like that. So Alessandra, I'm sorry I went over my time, but I'd love to answer questions now.
Great, thank you so much, Ed. That was fantastic, and I do want to encourage people to go on to the Peers for Progress website, which we have a picture of here, for the materials that I think will be available there, training materials and also some programmatic materials that might help you start a program like this, or help put structure around a program you've already created, or maybe give you ideas on how to expand a program that you already have. We have a couple of questions here. One from Catherine Williman. Hello, Catherine. How are you? Nice to hear from you. And she wanted to know, how do you measure the impact of support through texting?
Good question. Well, the big challenge with texting is to get a handle on the population that's texting. If we do a study where we recruit people and then we have them text each other, we can just measure the impact directly. For example, a program, one of the 14 programs we promoted or supported in Uganda, directed by Dr. Linda Bauman, emphasized texting among patients in Uganda. But in terms of the broader kind of free texting that's going on just across the web, it's a challenge to get a sample of people who are texting and then study how they're doing. But people are doing that. They're recruiting samples of people through the web and then studying in a fairly naturalistic way how texting is improving health, both by survey measures as well as in some cases by clinical measures.
Great. And another question related, you can see that the digital age is upon us, because another question that's come in is if you have any insights on how to encourage emotional sharing and support in a digital environment. So maybe the communicating digitally inhibits emotional sharing because it doesn't have that face-to-face element to it. Is there any way to encourage that and to make it easier for people as they start to address their issues?
Sure. Actually, I think that it may frequently be the opposite. If you talk to survey researchers, they'll tell you that they get better results by telephone interviews than by face-to-face interviews, because over the telephone people are more candid. When face-to-face, we're more inhibited by social processes that want to make us put a good face on ourselves, literally. And what we find is that people are exchanging through web-based channels, and especially channels that provide them anonymity. People are exchanging really emotionally very powerful messages. But this is very cultural. For example, in China and in Cameroon, in both cases, people were saying that they're able to share with the group things that they couldn't talk to with their family or with their physicians, because with the group they feel that there's less, they're not putting a burden on people, that they have to be helpful or do something. So it turns out to be very, very cultural. I think what it is that we all human beings are assisted by being able to share our emotions, but exactly with whom and how and through what channels may vary considerably. But I think emotional support through digital channels is really an important area for future work.
Right, especially for people who are caring for people.
Yes.
Because oftentimes they don't have the time. Another question that came in was, how do you engage? We have a few medical doctors on the line here, and they want to know how you engage the clinical community in terms of recruitment and involvement. I think sometimes doctors are worried about referring a patient out because they can't do the quality control. So how do you create that relationship of trust, and how do you involve the clinicians so that they don't feel like they're losing their patients to a support program?
So I think there are a couple of levels. First of all, the organization, if it's outside the clinical setting, the organization doing the peer support program needs to really develop a relationship with the clinicians they want to work with, or with the clinical setting they want to work with, so that there really is at an organizational level some trust and reliability developed. I think this is really an important challenge for peer support program. If I'm a physician or a nurse and I refer a patient to a service and they come back and tell me that, they told me that they're not running any programs for 3 months, everybody's on vacation, I'm never going to send anybody to them again. So the programs need to be quite reliable and responsible in how they receive referrals or recommendations, and that really again goes back to the organizations developing a good relationship. I think then the clinicians need to become familiar with the program, know that there's backup, know that there are provisions for peer supporters to get help when they get questions that they don't know the answers to. They really need to have faith that their patients are going to be treated responsibly. And then the payoff of all of that, my favorite quotation was from a Dr. Hinojosa in a clinic in Laredo, Texas, on the Mexico-U.S. border. And he talked about how he was initially concerned about the program, and he didn't think it would work, and he was worried about patients getting bad information. And he ended up realizing that with the peer support program in place, now when a patient has depression or is concerned about things, he's able to refer them to the peer supporter who can really take time with them. And as he put it, I get to practice medicine. So I think in the long run, physicians realize that having these kinds of resources available to them helps them do a better job of what they went to medical school for in the first place, to practice medicine.
Right. I think that's a really powerful point. I think sometimes we forget that in order to cure a patient, you have to help them with both their heart and their mind, and so this peer support is a way of supporting patients in their as a whole being.
Right.
So that's very interesting. And then another question that I actually just had: how many of these peer support programs are based in hospitals?
Oh, I don't know that we have a count of that. I think around the world, many peer support programs are based in health systems, not necessarily hospitals, but for instance, in Pakistan, the lady health workers in the primary care system. In Thailand, the village health volunteers are in the primary care system. But many hospitals now are developing peer support services for specific services. For example, it's commonplace in U.S. hospitals for cancer services to have cancer navigators who help people work their way through all the different treatments and services that are available and that they need to be taking advantage of in dealing with their cancer. And I think people are developing peer support services around those specialty areas. Certainly in cardiovascular disease, there's growing interest in peer support and group programs for cardiac rehab.
And then with our last question that we have time for, do you have any examples of peer support programs specifically in Brazil?
Yes, there are many peer support programs in Brazil. I don't know I should, but I don't know the name that they go by in Brazil. But the Brazilian government has a very substantial initiative for peer support programs as part of the health system there. My colleagues at the University of Michigan, Michelle Heisler and John Pate, are doing quite a bit of research in Brazil. So Brazil is a real leader in the peer support movement. This is a really important point. I think, candidly, probably the most valuable models of peer support are not coming from the United States and Western Europe. They're coming from Thailand and Pakistan and Brazil and from China and from places all over the world. So this is really an area in which the whole world has a lot to learn from each other, and it's really exciting in that regard.
Would it be okay, maybe after the call, you and I can connect and you can give me some contacts so I can put the Brazilians in contact with some of the people
Yes.
that you know?
Yes.
Because I think in Brazil, there's also a lot happening on the NGO level in terms of helping people with diabetes and heart disease, and they want to be able to tap into an existing network. Now, we are summing up. First of all, I want to thank you, Ed, for the incredible work that you do at University of North Carolina at the Gilling School of Public Health, but also just for taking your time and for being open to working with some of the people we have on this phone. Please follow up with us at UnitedPatientsAcademy.org, and we can, or Ed will follow up directly with you. You should be expecting an email. And if you'd like to get connected into this network, please feel free to reach out either to Ed Fisher directly, who will be reaching out to you, or to us at UnitedPatients.org, UnitedPatientsAcademy.org. And I also wanted to emphasize one point. This is an English language webinar. We specifically chose an example of some best practices that are global. And I know you're hearing a lot of English accents on the phone right now, but this is not an American endeavor. This is a global endeavor. Of our 1,000 NGOs that are registered worldwide, they come from all over the world, and we actually have only a few Americans. So what we are looking for we have a list of incredible, great best practices from Europe and Asia, Middle East, Latin America, and Africa. And we would love to have other examples. If you could share them with us directly, that would be fantastic. This is a way, the Ask the Expert webinars are a way to share best practices and also to build a community of people who are doing great work, talking about the great work that they're doing, but also troubleshooting and sharing experiences and working through barriers and understanding that we're not alone as we try to improve patient outcomes around the world and in low and high resource settings, but really mostly making sure that we're doing our best for patients as they try to address the chronic issues they may have, the crisis issues they may have, to make people's lives better. So any recommendations of cases you've heard of, we will do all of the organizing. We will contact the experts. We're happy to have any of you share some of your experiences as well. You know, the United Patients Online Academy is all about building capacity for NGOs, by NGOs, for the NGO community. So Ed, 1,000 thanks.
Thank you, Alessandra. And I just want to repeat your promise that we will be in touch with everybody on the webinar to explore possibilities for a network.
Thank you so much. Thank you, everybody. Have a wonderful, wonderful 2017. I look forward to working with you this year. We all at the United Patients Online Academy look forward to a long and robust collaboration. Thank you very much.
Bye-bye, everybody.